pharmacists and friends. Today is April 11th, 2023. Welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen to find out how pharmacists and pharmacy students like me can improve population health, health equity, and patient care through advocacy and education. My name is Brindley Rosepars, and I'm a final year pharmacy student at the University of Rhode Island, working alongside the Rhode Island Department of Health, alongside my professor, Dr. Bratberg.
Hi, I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the College of Pharmacy and the Academic Collaborations Officer at the Rhode Island Department of Health. As a reminder to our listeners, the opinions expressed in this podcast by the hosts and guests do not represent the opinions of the United States government, the Rhode Island Department of Health, nor the University of Rhode Island.
Thanks, Dr. Bratberg, for your introduction, and I'm sure you are just as excited today to be recording our first full-length episode of Season 7. On deck for today is a lively discussion regarding the recent approval of Naloxone for over-the-counter or OTC use.
Yes, I'm very excited, and for her second time on the Regimen podcast, I'm pleased to be joined by my friend and colleague, Dr. Anita Jacobson. She's the Program Director of the Community First Responder Program, which educates communities about opioid misuse and provides resources to help address opioid misuse, including the opioid overdose antidote, Naloxone. She's also a clinical professor in the College of Pharmacy. Thanks for joining us today. Please introduce yourself, and we'll have the future Dr. Zanetis here introduce herself too. Tell us a bit about yourself and why you decided to join us.
Absolutely. Well, thank you for having me. You did such a great job introducing me. I don't know if I have anything else to add, but yes, as the program director of the Community First Responder Program, we do a lot of distribution of safer supplies and naloxone throughout Rhode Island, both in the community, as well as we are the centralized hub for naloxone distribution throughout the state for harm reduction organizations and nonprofits. And we have Ashley Zanetis with us today. I'll let you introduce yourself.
Hi, yes, I am also a final year pharmacy student in the PharmD program here at the University of Rhode Island. I'm very excited to be graduating next month. Very excited to be finally practicing pharmacist in the field.
Well, thank you both so much for being here. We are so excited to chat with you today about this topic. So before we actually dive in and discuss the approval of Naloxone for OTC use, first let's talk a little bit about Naloxone itself and a bit of its history. So Naloxone, or Narcan, as many pharmacists know, is an opioid antagonist used in the setting of opioid overdose, and it's available as both an injection and an intranasal spray. It is an overwhelmingly safe medication for use, and prior to its new approval for OTC, it was available by prescription, either written by a provider or through a standing order for a pharmacist to dispense without a prescription. Notably, Health Canada did remove Naloxone from their prescription drug list way back in 2016 to make it available as dispensed by pharmacists without a prescription. However, unfortunately for those of us in the US, many barriers do exist related to Narcan access. Cost may be a factor for those without adequate insurance coverage, and fear of stigma is also a barrier, not only for those seeking to have Narcan on hand for themselves, but also those seeking it for those that they care about. And so, as mentioned, we'll be discussing the recent approval of OTC Naloxone shortly. But before getting into that, I would love to talk to you, Dr. Jacobson, about your expertise with Naloxone education and distribution. You really do have a lot of extensive experience to create more accessible Naloxone throughout Rhode Island and all of its communities. So would you tell us a little bit about how you first got started working in harm reduction and then also the Community First Responder Program itself?
Sure. So we actually first got started in 2019. So we had a grant from the Substance Abuse and Mental Health Services Administration, SAMHSA, and it was a rural opioid technical assistance grant. So for people who are familiar with Rhode Island, we don't really have very many areas that would be considered rural by standards of other states, because we are a state that is 20 miles wide by 40 miles long. So we fit into the counties in many other states. But we do, even though we are such a small state, we do have pockets of areas along the north and western side of the state that are what we consider to be agricultural, rural communities. And there was less being done in those areas for harm reduction and naloxone distribution. So that was what made us eligible for that grant. So we started out, we got our funding in September of 2019. And as anyone who's worked with grants knows, it takes a little while to get it going, to get your purchase order set up, to get everything ready. and we were ready to hit the ground, and we did our first presentation on March 13th, 2020. And so everybody knows what happened the following Monday. It was all shut down. So we had to completely pivot. We had plans to do a lot of in-person events that all needed to pivot. So we pivoted to more of an online model. And we quickly realized it would be successful to do mail distribution of naloxone. So we got that up and running, and that really kind of became a big prong of our program. In the summer months here in Rhode Island, it's quite nice out, and there's a lot of farmers markets. So we did a lot of farmers markets, tabling events. During COVID, that was something we could still do. So we started there. We started in the rural communities, but people started to hear about us, and that interest grew. So we developed a collaboration with CVS Pharmacy. So they allowed us to come and set up a table in their parking lot. People going into the store, we'd say, hey, would you like to upgrade your first aid kit? We have some free naloxone. And we gave out a lot more naloxone in CVS parking lots than the pharmacy was giving out on any given day, week, or month. So
why do you think that was?
Well, people don't necessarily identify as either having a risk personally for overdose or being adjacent to someone who is at risk. And I think a lot of that has to do with stigma, of course, but also just, I think there's a nature to want to protect yourself from something that is difficult. And so if you have a loved one, a child, a family member who's struggling with addiction, I think a lot of times people just compartmentalize that. And when they're going into the pharmacy, they don't think to self-initiate to go up and ask for this. So us kind of being there and just making that offer, we really reached a lot of people who were quite high risk, who I don't think would have gone in to ask for it. And then we also do seminars as well. So we kind of have 3 prongs of distribution: the mail order, the tabling events, and then we do seminars for libraries, for the fire stations have hosted
fraternities
us.
On campus.
Fraternities on campus hosting us. So really any group or organization can request a seminar. We come, we do it for free. It's 45 to 60 minutes long, and we distribute naloxone. So those are kind of our 3 prongs. And Ashley just did one with me at PACE yesterday for the providers. So the nurse practitioners, physicians, pharmacists, they're the Center for All-Inclusive Care for the Elderly. So they wanted to start having naloxone. So yeah.
That's wonderful. Thank you so much. I remember a couple of years ago when I was a pharmacy student taking that training course and getting a mail order kit in the pharmacy when I was home from the pandemic in May of 2020. So it's definitely so great that you're able to reach so many different populations, whether it's students, whether it's people in the community, people that are high risk themselves, or even those that are adjacent or maybe caring for them. And bystanders as well is another really important population needed to reach. Speaking of that, the Community First Responder Program has had some really significant impacts across the state. And one example is published in an article last summer about a community member that saved a life less than 2 days after receiving Narcan from one of your booths outside of a local CVS. So would you be able to tell us a little bit more about that encounter and the education that you provide in communities?
Sure. So that was actually one that was run by 2 of our pharmacy students. So it was Eliana Spagnolo and Jacob Derby. They were on their service learning that they have 40 hours to do. And they had a tabling event. Someone came up, they were a yoga instructor, and they made the standard offer, would you like to upgrade your first aid kit? And they said, I don't really think I would have an opportunity to use it. I don't know. And they kind of said, well, it's free. You could save someone else's life. And they're like, yeah, all right. So they took a kit kind of, begrudgingly, just, why not? I guess, maybe I could be helpful. And as you said, 2 days later, they were pulling up to a public park and someone was screaming, help, my friend is dying. Does anyone have naloxone? And he was like, I actually do. And so went into his bag and got that. And they were able to save that person's life. So, really, it's really exactly the message that we've been giving, which is it's like a fire extinguisher. You just want to have it just in case. You might never need it. In fact, in some ways, you kind of hope you never have to use it, but you have it there just in case.
What an impactful story that is. And I think it really just does illustrate the point of how valuable this drug is. And the fact that it is so safe really just goes to improve the argument that having this approval for OTC use is really a beneficial thing to our communities. And so now to kind of transition our discussion over to the recent approval, I would love to get all of your thoughts. So what was all of your overall impressions when you first saw this recent approval for OTC use? Dr. Bradford, would you like to start?
So we've written a lot about this actually with our pharmacy students. We had a publication, the Health Affairs blog, that with the future Dr. Kendra Walsh, who was my P4 student on rotation, on my public health rotation. And so it's really exciting because they accepted it right away, and then all the OTC conversations started happening. And I'm excited to hear Dr. Jacobson was actually an expert on the panel for the FDA panel in February to talk about the first product. I think it's really important. You started earlier, Bryn, talking about there's intramuscular or injectable naloxone, and there's intranasal naloxone. The OTC approval is only for one form of intranasal 4 milligram approval. There are other products that still remain prescription. There's higher potency naloxone intranasal products. There's a higher potency injectable product. And then there's the product that actually has saved the most lives. I think it's really important that our listeners know that the most commonly used titratable injectable intramuscular naloxone is one that is distributed through our colleagues to harm reduction organizations. Because as we were saying, it's fantastic the work that we're all doing here in getting naloxone to anyone who is a first responder, and everyone is. But really, the most common group of people that revive people are people who also use drugs. And so it's all about using with someone, having that support system, a highly vulnerable, marginalized group, but there's still a social network there. And so to utilize those networks, it's important that to note that we don't have that as an over-the-counter access. It's still available through harm reduction. So I think, the biggest barriers are still stigma. Just because it's over the counter doesn't mean that it's going to be in the aisle to grab and check out on your own. And if it's $45 or if it's in a container, in our paper with Dr. Walsh, we talked about comparing naloxone over the counter with the most currently expensive over-the-counter drug, Plan B, emergency contraception. So here you have sort of stigmatized drugs. Yes, they're available over the counter, but if they're $45 or $50, I don't blame pharmacies for locking them up, but then you have to sort of go to that effort to ask them to unlock it. It's not, oh, I want that $50 electric toothbrush. It's still going to be a barrier to talk to people. So it's yet to be seen sort of where is it going to be? Are you really going to have it in a gas station? Is it still going to be behind the counter at the gas station? I think more access is good, but I think we still need to solve sort of the problems. Dr. Jacobson and her team and students are handing out intranasal naloxone for free. Over-the-counter use of that product is not going to change what we do. As a state, we distribute and use data very effectively to get it in the hands of those who need it most. So that's not going to change. But in other states where we don't have such a high use of and supply of naloxone, like Alabama has very strict restrictions, over the counter is going to be transformative there. So that's sort of my overall thoughts.
Absolutely, and I'd love to go back to the point that you made about the concern for cost with this medication. So as we were talking about, approval is a great step towards increasing accessibility, but if there's still the cost concerns, how will this impact how accessible this switch really is? So I'd love to get your thoughts on that.
Yeah, so we've actually had a lot of conversations about price and sort of no one has a crystal ball, no one knows what the price is going to be. But if I'm going to use my crystal ball for a minute here, I would anticipate it's going to be somewhere in the $20 to $40 range. I would be very surprised. $45 is pretty much around the pricing right now that most groups who distribute volume of naloxone can get it for. So I would be surprised if there wasn't a little bit of a drop down. I think what's going to be the decision that a pharmaceutical company is making with pricing is, if you have a lower cost, you may see larger volume, and if it's higher priced, you getting more for that product, but there will be a lower volume. And so where is that magical number? And I'm sure they have equations and things that they do to figure all of this out. So what I do know, though, is there will still be this special interest pricing that will be available. So for schools, law enforcement, harm reduction centers who right now are able to access at that $45 public interest pricing. Whatever the OTC price is, there will be a set public interest pricing. So we're all hoping it's less than that, so that it will be an advantage in that way. The thing that, really frees it up though is sale online, right? So online sales, could be, again, that issue of going up and asking for it and behind the counter, maybe it's just you put it in your cart at Amazon and it's just easy peasy to check out and it's delivered to your house. The other thing is for state to state distribution. So I right now have a SAMHSA grant, again, rural, but it's for all of New England.
Big multi-million-dollar grant.
Yes, and so
Just to be very clear, it's a big grant.
right, and so, but we feel a little bit like our hands are tied because especially as a pharmacist, I know there may be harm reduction organizations that do interstate distribution, but as a licensed pharmacist, I really get held to this, pretty strict standard. We have to make sure that all the I's are dotted, all the T's are crossed. So I can only distribute naloxone in Rhode Island right now. So here I am going to Maine last week. I couldn't bring my supply of naloxone to distribute. So we worked with a harm reduction organization there to bring it. And, and it didn't feel great. I would have liked to have used our grant funding to purchase that. And also to open up. So I'm excited about the other modalities. I also am very confident that health insurance will cover the over-the-counter. I would be absolutely shocked if there's any third-party payer, state Medicaid, anyone who doesn't cover this. The return on investment is just overwhelmingly clear. I think it'll be similar to nicotine replacement products going over the counter. So the patch, the gum, the lozenge, they're all over the counter. They're all covered by health insurance, many of them with zero copay. Differs state by state, and this will also differ state by state, but I'm not super concerned about that either.
And I have talked to the Medicaid director who I asked the question directly on a call about a different topic, and they said we're 100% behind that. So I think that's good to hear, at least from a Rhode Island perspective, but I agree, I think it'll be available. And I think what we've called for is that all the other possible venues that you can get naloxone, they should be available there, and should, if people do get recommended by their pharmacist to get naloxone, we should have it behind the counter to give to them. Now, some states actually already allow technicians to counsel naloxone. Now you just have an over-the-counter product that they can just sell to them and don't have to use insurance, or if they want to use insurance, because there's competing interests about maybe if I pay $20, it's still anonymous and I've got $20 to spend. If I don't have $20, I'm okay with it being on my Medicaid because I don't have the 20, but I want this. The pharmacist convinced me to have it. So I think we want it, both behind the counter, in front of the counter, on the shelf, in a vending machine, all those types of venues that again we're already doing in Rhode Island. I wanted to ask you, Dr. Jacobson, about the idea. I know that all the naloxone in the state, I think, has your name on it. So because it's a prescription product and has to be labeled according to federal guidelines. Is there any advantage to sort of having that labeled prescription product not in the hands of folks who are in the best place to administer it?
You mean, do you think the label brings some sort of benefit?
Sure,
I mean,
sure.
the only benefit that I see with having the labeled naloxone is then a resource to call. So our
Right.
phone number is on there. I would say, last year we distributed about 37,000 kits with my name and phone number on it. And I think I got 5 phone calls.
Right.
So, but for those 5 people who they were like, wait, I have a question, or somebody, gave me this and I'm not really sure what it's for, or whatever might have happened. It is nice for them to have that resource and sort of knowing where this came from. I think, also with law enforcement, seeing that this is something that was distributed by a program, they know our program now at this
Right.
point. So, in a small state like Rhode Island, I think there's some connectivity that can be made with that labeling. Our website's on there, things like that. I think the over-the-counter labeling, having looked at it, is going to actually be more user-friendly,
Right.
As it would have to be. I think in an emergency situation, we want people to be trained so that they're not fumbling to read the packaging, right? So it'd be ideal for, there still to be those resources, that counseling that's available for folks.
So exactly, just to go into education, I remember my very first year of pharmacy school, naloxone was the very first medication that I learned how to do a patient counseling on. And so this was something that I think was very highly enforced and ingrained in us in the pharmacy curriculum. And so now to go off of your point, having all of these different venues where people could be getting naloxone from, how will patient counseling and patient education kind of play a role into making sure that still happens and you have someone being able to be a resource, whether that's immediately on the point of transaction or having community members that people can turn to? What do you think that's going to look like with this switch?
I think it's going to depend on the site that they're getting it from. So whether, you know, a pharmacy could put a sticker with a QR code on there that then people could, with their phone, it would link to an instructional video, something of that nature. I think there's a lot of different options. You know, I wish that as pharmacists, we had our time sort of reallocated in a way so that when people bring a prescription in or come up to the counter, it's the pharmacist that they're talking to. You know, that counseling is an opt-out model, so we counsel everybody unless you turn us down. You know, I know that that's not the reality of what's happening. But it's safe and effective to use if people don't know anything, if they don't get any counseling and they see someone, you know, they can hopefully with this quick start guide at least quickly look and know, okay, nasal spray, spray in nose, call 911, push down on that chest rapidly, you know, the basics. So it's going to vary on the setting. Obviously, ideally, we'd love for everyone to get fully trained, but we just have to keep making those opportunities available.
And I think it's important to build on the FDA call. There was extensive discussion, and I learned things, and I feel like I've read everything there is to know about naloxone, about what goes into I handed you this, do you know how to use this without training? And so that goes into, for those listening, that a lot goes into over-the-counter training, assuming that you're not getting trained. So when you look on the back of an ibuprofen bottle, it tells you exactly what toxicity is, what to look for, when to call a doctor. We all learn about self-care and teach self-care to the students. Now naloxone is part of that, or at least one form of naloxone is part of that. And I think that's what's limiting, is that people have fought, and I've been at meetings at the FDA where you have this vial and a syringe, and they're like, how can people possibly draw up this, vial and inject it without education? And, you know, I've taught ninth graders that in 2 minutes. Yeah, I mean, I know that that product doesn't require a lot of education, and I hope the FDA's listening, as they do, is everyone should subscribe to the regimen to try to make sure that we get increased access, because it may be $20 for the intranasal form, but the intramuscular form could be, $5. So we have to think about that sort of cost containment, and they work equally well. And I think that's important.
And I think you already said this, but it's worth saying again. I do frequently, when I'm doing tabling events or outreach events, have people who use drugs tell me they actually don't want the 4 milligram nasal spray, and they ask me preferentially for the vial and the syringe, because again, it is titratable. So the reality is, somebody who's actively using and is not in a place where they're ready to go into treatment and recovery, being reversed with 4 milligrams of intranasal naloxone, will precipitate withdrawal. And we're seeing that people who use fentanyl in particular have to use very frequently, sometimes every 2 to 3 hours. So, that is a loss of time for them. And unfortunately, what sometimes happens is, in an effort to then overwhelm that naloxone to get back to a state where they're not feeling terrible and sick, they may take too much to try to compensate for it. So there is a population of people, and it's not enabling, it's keeping people alive until they can get connected to treatment and recovery. And that's always a goal for us. We're always trying to help people know what resources are available.
I think that's the greatest. I'm just going to keep asking questions. Sorry. The idea is, we've worked on this for many, many years, but to walk into a pharmacy and to see a wall or an end cap of just Narcan, that in itself is the win, right? Even if it's locked up, even if it's there, I think that like when I see EC or I see other products that people use and need to reduce their harm of doing all sorts of things, if you see that accessible, it was not that long ago that condoms could only be bought by the pharmacist.
Right.
And I don't think that anybody really wanted to do that,
Right.
Try to them and be like, hey, I need this thing. now they can just buy it off the counter. I think even if you're not buying it over the counter, if you're getting it through other means or you're ordering online, the fact that you see it destigmatizes it. And we've done a lot in Rhode Island and a lot of places to sort of put ads in different places, but here you say, wow, this is like a normal thing to get. I think that's the important thing. And I think you've got questions on where else it could go.
Yeah, absolutely. So thinking of this similar to your anecdote and thinking about how Narcan can be seen as similar to a fire extinguisher, it's great to have, safe to have on hand in case of an emergency. That's something, fire extinguishers are something we see in every building just in case, although we hope we never have to use it. It's there in case of an emergency. So thinking about other places where you would typically have fire extinguishers and other safe measures like an AED, do you think this product should be something we should be keeping in buildings like campuses, schools, libraries, other public places in areas next to those safety equipment like fire extinguishers and AEDs? Do you think that's something maybe we should start moving towards now with the switch?
I think absolutely, if nothing else, to help destigmatize it. The reality is the majority of overdose deaths do occur at home, though. There of course are overdose deaths in public spaces, and so this would address potentially or increase the ability to respond to an emergency in a public space. But we also really need to not lose focus on that the majority are happening in private spaces. So we need a multi-pronged approach. I think there's a lot of benefit to having it right there with an AED in terms of accessibility and reducing stigma, which again is just so important. But I don't know if even if we really did that, we would still see a significant number of overdose deaths occurring at home. So we have to figure out how do we get naloxone. As Jeff said, people who use drugs are often the rescuers. So how do we get this marginalized group of people who are pushed to the fringe of society to have just ready access to naloxone?
Yeah, I think we talked, one of my favorite conversations we've had has been, why can't we just put naloxone in coolers and put it in places where we have data that there are literal hot spots of where overdoses occur? So we know, and having looked at this data from the health department, we know exactly where these overdoses are happening. So we know we need, and we know people are reviving people there too who are carrying it. That's the other interesting thing is like we talk about, I can mail order my naloxone and then it sits in my kitchen drawer. And yet when I'm walking into the hospital, there might be somebody having an overdose. This happened to my student. They saw someone having an overdose. They had naloxone, but they never thought to carry it, right? So that's the other kind of stigma is that you can get the training, as a pharmacy student or a first responder, you can have the naloxone, but do you always have it on you? When you're in a large group or in those settings, it's not you never know when it's going to happen. Maybe you know where it's going to happen more likely, but making sure we have public access to naloxone. Again, that's another advantage to over-the-counter access is now you don't have to go through all the rules you have to go to. Let's put it out there and make sure people know where to access it.
Well, and let's think strategically about where it might be needed.
Right.
So I would say public restrooms, would be a real goal is to have that. And then you do have to have some dedicated staff to replenishing it, because it isn't something, there would be, however many kids in there, and if they get used up, you need to replenish it. And if they don't, somebody needs to be kind of monitoring the expiration date. But it's a pretty low level of, effort that needs to go into that. But we need to think about where is the space where this would be most likely to be used. It might not be the space where the AED is. Like maybe the AED is located in a very visible place for everyone to see. Maybe the naloxone actually would be better in the bathroom space or another space. So there's pros and cons to both, or maybe you have a kit in both locations.
And it's there to help everybody. I mean, the thing is, if it's in the bathroom and you know where it is, you still know that if it's, where do we have syringe disposal? Where do people use syringes? They may be injecting drugs. They may be injecting legal drugs.
Right.
There's still an injection. So I'm a big proponent of syringe disposal for all people who use syringes. So It's not enabling drug use. It's just enabling better disposal. So again, I think a lot about when I go to airports and things and I see, or any kind of public bathroom and you see a syringe disposal, I go, that's great for the things that I research, but it's really great for everybody, right? It's like curb cutouts from the American Disabilities Act. That's great for people who use wheelchairs and people who push strollers or people who have mobility issues. So we have to think sort of, we're not enabling anything here. We're just putting it in places And I think if people see naloxone Ashley, you're quiet, I'll ask you a question. So if you saw naloxone in public restrooms, would that change your impression, or would it change the impression of people you know? What do you think?
No, I mean, as a pharmacy student, I feel like it's definitely a step in the right direction to increase accessibility. You know, other people may stigmatize, they have other opinions, but I would say it's definitely a step in the right direction.
Great. And so while we're on the topic of stigma as well, what do you all think in terms of the OTC approval, if it's actually going to increase access for those reluctant to ask a pharmacist or provider for a prescription, particularly those in fear of prejudice or discrimination? Is this approval actually going to help increase access, or depending on where the location is in terms of some of the barriers we've talked about before, whether it's something that's locked up that you have to ask for, how is that all going to play a role into the difference in being able to put this product into more people's hands?
I would say that's going to be a store by store decision, and it may be a location specific decision as well. So, there are some stores that you can walk into where most things are freely, just in the aisles. And then you can go to a different state or a different, zip code, and there are things that are freely available at your neighborhood store that are behind the counter or behind glass locked up in that region. So, I don't think, certainly there's no requirement from an FDA perspective. This is not being issued as behind the counter. This is being issued as over the counter. So it could be freely accessible, as Jeff said, on an end cap where people could just come in and grab it. Now, so that's going to be an individual retailer, district manager, supervisor, independent pharmacy, whoever it is, would decide that for their space. It's unfortunate, but I think in our more urban sections of the world, it will probably most likely be more restricted, and those are the areas that disproportionately have the higher numbers of overdoses. So that is problematic. My hope, though, is those are also the areas that have more harm reduction resources available. So harm reduction agencies, organizations are more commonly in our urban communities because they can reach the largest number of people. So this may be actually in a way opening things up in suburban and rural areas that is maybe just a different demographic of people. So the OTC may disproportionately push in that direction, and that may be okay, because it will also loosen up our harm reduction organizations, hopefully bring down the price a little bit. They don't have to label them all. They can just, so that I think it's going to benefit both areas, and it'll be something for us to see how that kind of plays out.
Yeah, I think that it's very interesting, because I think that, so there's stigma, but I'm a person that was raised in a small town in Minnesota, and everybody knew everything. The pharmacist knew everything. We all had the same doctor. We all had the same dentist, and you felt your privacy was there. But like the moment that one piece of it, and it's boring, right? So I love my town. Nobody knows where I'm from, but live in Massachusetts now. But I know that like once there's one little tidbit of information, you either have the sense or a perception that it's around. Now it's this way where if it's over the counter, you can grab it, and it probably will be accessible. And maybe the people will say, and one of the other problems that surveys have shown is why do some large percentage of pharmacies don't stock naloxone? Because it's not being prescribed or dispensed.
Right.
It's going to be really interesting to see that shift between prescription naloxone to stocking over the counter in these areas, and realize there actually is a really great need. People are buying it, and that will be the self-generating thing. Tracking it will be interesting, but I think that, what I recommended to our health department colleagues, because I was asked this question, is like, well, how do we track OTC naloxone? It's going to be really difficult, all these potential venues. And I said, we'll know to track it when we see the prescriptions go down. Right now, we have a pretty steady amount. We have a co-prescribing mandate in Rhode Island. That's not going to go away. So for higher risk prescription drugs to co-prescribe, or people with previous overdose or opioid use disorder that recommended it, I think we'll just see where it goes, and then of course we'll look at the overdose deaths epidemiology.
Well, this has been a really great conversation regarding this recent approval. Dr. Jacobson, it's been so great to hear from you, and future Dr. Zanetis, thank you for joining in on this conversation as well.
So Brinley, what's the regimen for over-the-counter naloxone?
I think that the regimen for over-the-counter naloxone is best described like how Dr. Jacobson said earlier about having a multi-pronged approach. I think it's going to depend on accessibility and advocating for the most accessible use in your community and your role. So whatever your role as a pharmacist or pharmacy intern, pharmacy student may be, I think advocating for the most accessible pathways in your community. So whether you're the district manager choosing whether it's behind the counter or in the aisles, if you're a pharmacy intern, talking to people at your store and in your community and advocating for that choice to be made. If you're working at the Department of Health, starting initiatives to get these into public bathrooms and other public spaces where it is easily accessible. So really the regimen is advocacy and getting this to the most accessible places. So this really has been a great discussion here today, and I'd like to thank our guest, Dr. Jacobson, and future Dr. Zanetis for being here and providing such great insight throughout our conversation.
And thanks to the future Dr. Rose Parves here, and be sure to follow all her posts on @PharmD Pub Health on Instagram and Twitter, and turn on post notifications so you never miss an episode. Smash that subscribe button now on Spotify, Apple Podcasts, YouTube, Amazon Music, or wherever you listen to podcasts.